Hello and welcome everyone to the Sustainable Care Conference 2021. I'm Shereen Hussein, a professor of health and social care policy at the London School of Hygiene and Tropical Medicine in the UK. I'm also one of the co-investigators on the Sustainable Care Programme of research, leading a research theme on the role and experience of migrant home care workers and the implication of a changing immigration policies and landscape. I'm delighted to be chairing session 5A, Care Mix and Aging in Place, as part of theme 5 of the conference, Sustainable Care at Home, Understanding the Care Mix. In this session, we will have 3 presentations followed by a discussion, and then we will open the floor for some questions and answers. I would like to introduce our first speaker, Mikołaj Zarzycki, who will be talking about exploration of value and motivations to provide care amongst British informal caregivers and care recipients, dyads. Miko is a PhD student and an early stage researcher at the School of Psychology at Bangor University, the UK. He conducts his PhD as part of a Marie Sklodowski-Curie ITN network called Entwine. The main focus of his project is on caring motivations, why people provide informal care, what motivates them, and what determines continued caregiving. Without any further ado, I provide the floor to Miko.
So yes, thank you, Shereen. My name is Miko, as introduced, and in this presentation, I will tell about my study, qualitative study, which explores informal caregivers and care recipients' experience in the context of personal values in relation to their motivations to provide care. So next slide, please. Yes, so starting with the definition of informal caregiving that we applied in the study, it is a quite broad definition. So an informal caregiver is defined as a person who provides regular unpaid care to a loved one, and this could be a family member, but also a friend, someone outside the family, to a person with any type of care need, actually. And why do we do what we do in the study? So in the next few decades, the needs of ill and old people will basically increase, while the availability of informal caregivers will decrease due to different factors, mainly demographic ones. And if we look at the research, informal caregiving research, which looks on the influence of informal caregiving on informal caregivers and care recipients, we can see that the consequences for the dyads are quite typical and are usually negative. Given all the changes described, there is a real risk that the motivations to provide care might be undermined. Therefore, we look at the study mainly at the motivations, but also in relation to values. And here, please, next slide. So when it comes to personal values, the significance of personal values and the value system has been highlighted by a wide range of authors from different theoretical methodological traditions. In psychology, it dates back to Allport, up to now, for example, the Schwartz theory. But in our study, we asked caregivers and care recipients to take photos of their experience. And we basically ask them to take photos of the things that they value the most, so the things that make their life feel important to them. Personal values are not studied a lot in informal care, and in a previous meta-synthesis of qualitative literature that I conducted all together with my colleagues, we have found that values are distant yet foundational for the caring experience. With motivations, there are basically the reasons why a person engages in a particular type of behavior, in this case, caregiving. So this is the theoretical uptake we took. So the reasons really are the motives, and we also ask them to take photos. Next slide, please. So the main aim was to explore caregivers and care recipients' personal values in relation to motivations in these dyads. Next slide. When it comes to the method, so with the design, it was the cross-sectional mixed approach study, exploratory in nature with the participants. So 8 caregivers took part and 7 care recipients who were stroke and or brain injury survivors. All 8 caregivers considered themselves as the primary caregiver. 2 of them were male. With the care recipients, 5 of them were men. Also, we had different types of relationships. So we had parents providing care to their adult children. We also had spousal caregivers, and 2 caregivers were providing care to their sibling. With the procedure, it started with the photo voice storytelling methodology. So we asked participants to take photos depicting some issues in their experience for 2 weeks, and it was prior to the semi-structured interviews. When it comes to analysis, we only applied the first 2 phases of photo voice method, so selecting and contextualizing. Selecting is basically choosing the photos, and contextualizing is telling stories about the meanings of the photos that they have. So this is, and the codifying, the first stage of photo voice was not applied, and this is something what we usually understand as analysis, because we wanted not to be really constrained only to the photos. And in this way, we deepened the analysis and applied interpretative phenomenological analysis to the whole transcript. The next slide. So findings for the caregivers. So we identified 8 superordinate themes, and from these 8 themes, here I present only 3 that, in our opinion, basically relate to values. And these are the value of family, obligation and responsibility, which refer to the value of being responsible and the norms of responsibility, and the nature of relationship. All these values and themes can be also understood as motivations themselves, strong for motivations for providing informal care. The next slide. So we'll start with the value of family. Next, please. Yeah, and so the family was mentioned prevalently by informal caregivers, usually as the first and one of the most important values that they held. They expressed strong identification with the idea of family, which could refer to familism. And for example, here we have Paul and the picture that he has taken of his family. He provided care to his adult daughter, Julia, who was recovering after the TBI and was fully dependent on him, actually. And he says, I've always had my family as the number one thing in my life. Family first, and after that, other things, sort into line. But also, it was reflected in different other ways. So next slide, please. Yeah, so caregivers were also talking about, for example, spending time with their family, maintaining a sense of home, being loyal to each other, or the feeling of solidarity, which can all be seen as exemplifications really of the familism. And when it comes to the home, for example, there's a picture of home taken by Emma, who provided care to her adult son. She's saying family home, that's the most important thing. While Paul calls home the sacred place. So that's another example of this, how they talked about it. And the next slide, please. So on the next slide, we also have this notion of family being both challenging and rewarding. So the caregivers also express the challenges and hardships that they had to gone through in their caregiving journey, but at the same time, they still attached a lot of value to family, saying, for example, that at the end it's worth it. So, for example, Emma here speaks that they take so much from you. She means her family and caregiving as well, but it's all worth it. Moving to the next superordinate theme, so the next slide, obligation and responsibility. This refers to the norms internalized by caregivers. And here I only refer to the 2 sub-themes. So starting with the first one, next slide, it's marital obligation. Carrie, who was providing care to her husband, Harry, took this photo with their hands And she's saying, I took that picture that was to symbolize marriage. Harry is the one that I give the care to, but I struggle with that label. I'm not his carer, I'm his wife. You know, in a marriage, it's mutual love and respect. And it's quite clearly seen that she refers here to, well, to the norm of being wife, of being in a marriage, and actually fulfilling the marital vows that they had. So that's one of the motivations that she held for her caregiving, but also it was seen in parental caregivers as well. So moving to the next slide, please. Also, parents providing care to their adult children express kind of duty to provide care. They were speaking about a lifelong duty to provide care, you know, being responsible for the life that you bore until the end. No matter, you know, they were often saying that it's never ending for them, especially as their adult child had either a traumatic brain injury or a stroke, and they had to help them. So, for example, Emma says here, I mean, you know, the whole word mother, that's a strong word, isn't it? You give life and you keep it. It doesn't ever change, whatever the difficulties. Moving further to the third superordinate theme. So next slide, the nature of relationships. And this, so here I will present the three sub-themes identified within. So starting with the first one, and the next slide, is the affectionate feelings. So basically, it was mainly love that they were talking about and describing. Carrie and Shereen were both spousal caregivers. And here's a picture of Harry, Carrie's husband, sorry. And she's saying, if you didn't love someone, how could you be there 24/7? And Shereen is saying, if you love somebody, you will automatically give them care. You don't question it. Caregivers, speaking about their emotions and feelings, usually refer to this affective property of automaticism in what they did when the situation required them to provide care. And moving to another two sub-themes, so another slide, so relationship quality. And this refers to the current interactions within the relationships, the strength of the bond between the carer and the care recipient, and care recipient's gratitude. And here, basically, caregivers felt more motivated if they felt more recognized and appreciated by their care recipient. And here we've got Paul, who is saying, the bond that we have as a father and daughter is endless. Then the best reward that I get out of that challenge for me, caregiving, is her face and her thankfulness for doing it. And the picture was here to symbolize that when he broke his leg 2 weeks prior to our interview, and you know, he wasn't functioning as he used to, the care recipient bought him a fire stick, and he was showing that was the way to show her gratefulness, especially as for example, for the care recipient, it was not always easy to go and buy something. So the next slide gathers the findings for caregivers and care recipients. And the care recipients basically repeated, for example, the theme of the value of family and the nature of relationship. With the nature of relationship, they, however, focus more on the reciprocal aspects of the relationship. But with obligation and responsibility, even though the perception of caregiver's obligation was seen in care recipient's description. So, for example, the caregiver could say, I provide care because she's my daughter, while the care recipient could say, well, she provides care because she's my mother. But apart from that, the most evocative theme was focused around regaining independence. And on this, I will focus very shortly now. So the next slide, please. So yes, regaining independence as a theme relating to the loss of autonomy and independence as a direct answer to the health condition that was altered, so TBI or stroke. So showing the next slide, please. The value of independence was highly reported by care recipients. For example, Tom, who nearly died a few times because of his very severe condition, says it's something you kind of take for granted until it's taken away, and then you miss it a lot. So this was something that care recipients were focused more on. And the next slide, please. It was also related to, oh, one slide is missing, but it's fine. But it was also related to stigmatization and discrimination. And here, sometimes it was clearly seen, their disability. So, like, for example, twisted body. But in many cases, it was an invisible disability, and care recipients felt stigmatized because of their because of their condition. And for example, Joanna, receiving care from her mother, says, "It's a perception of disability that I don't like. What people see. I have a lot of motherfuckers to prove wrong. I can do it." Again, it's related to regaining independence and fighting with their loss of autonomy and the perception of disability that was also making it harder for them to live. And on the next slide, relating to discrimination, she's also saying, "Don't judge me without living in my brain. I don't want people to forget that actually Joan still has a brain injury because I look okay." And then she says about, well, her neighbors who call her around to randoms, which I go ironically, haha, that's funny, but I think bastards, so it hurts. But if I had no arm, no sympathy, and that's very painful. So basically, these were the descriptions of emotional pain that they experienced, also making it harder for them to be independent in their life, especially if we take into consideration that if this was an invisible disability, which meant, for example, the loss of literary skills, and some of them were before highly educated, they couldn't write or read anymore. It was hard to adjust to this new world, and the whole reconstruction of the self was an important topic. And moving now to the discussion of this findings. So the next slide, please. So for the research and theory, basically we have tried to demonstrate that values, actually have an important significance for caregiving and care receiving meaning and motivations perceived. They could be even, equalized with motivations in many cases. There is a limited research and theoretical discourse on values in informal care, especially when we take the theoretical discourse on values. The only one that I have found was developed by Spanish researchers based on ACT theory and nothing else. So the wider perspectives could be also incorporated more. The value of multi-methodological approach undertaken here in the study. So, combining photo voice methodology with IPA, phenomenological study. And photo voice is quite a new and rarely used in health psychology, where participants have this possibility to take pictures and relate to their experience based on that. And the main implication for theory would be to go beyond the basic dichotomy of intrinsic and extrinsic motivations that is commonly applied in quantitative research, which is also quite scarce, but the one that we have presents inconsistent findings. And that might be the reason why, because the motivations seem to be diverse, seem to be unique and fluctuating. So that's why this basic dichotomy, mainly, deriving from self-determination theory by Dechi and Ryan, is not sufficient. And moving to policy and practice, so it would be important if personal values of both caregivers and care recipients were recognized by support providers, service providers. Then the support could be more tailored. And we can see that the main narrative was focused around more individualized, compassionate, and person-centered care in relation to caregivers' values. In relation to the caregiver assessment, it could be more sensitive to caregivers' values and motivations for caring as well. So we can see. Addressing care recipients' stigmatization and discrimination is a societal issue and should be societally addressed. And also, as we saw, the loss of autonomy was not only a problem for the care recipients; it's also the problem for the caregivers, and it was identified as one of the as one of the areas requiring psychological and practical support for both caregivers and care recipients. They had a lot of dilemmas and doubts arising around this issue. So that's it. Thank you very much. So the last slide says basically thank you. Thank you for listening. And to the stories of caregivers and care recipients. Yeah.
Thanks, Miko, for your presentation, highlighting really an important issue of informal caregiving and the relationship between the caregiver and care recipients. I would like now to introduce our second speaker, who is Dr. Katharina Pelzelmayer, who is going to present a feminist appraisal of caring communities. So Katharina is a senior researcher at University of Applied Science, Zurich, Switzerland. And Katharina investigates questions of gender, care work, health and mobility from feminist and gender perspectives. Her current projects include an Age Foundation project on the political economy of family caregiving and the Swiss National Science Foundation project on care and communities, which she will give reference in her presentation today. Without any further ado, please, Katharina, we are interested to see your presentation.
Thank you, Shereen, for this very kind introduction. I'm very pleased to be here today, even if it's online. And in my talk today, I'm going to talk about a very contemporary application of the notion of care, at least in the German-speaking parts of Europe, and that is the notion of caring communities. And I'll look specifically at the ways in which feminist scholarship on care and caring communities approximate and interact. So, next slide, please. A very brief note on the context in which caring communities have emerged. So various systems of care are under mounting pressure, be that family care, community care, or state care, and there's increasing reference to a notion of crisis in care provision. For those who can afford to, the private sector offers several paid solutions, such as living care. Others, however, have to turn to individual and mainly unpaid arrangements and look for care and ask for care for family members, neighbors, or even themselves. In short, as we all know, there is increasing demand for innovative and sustainable care models. This is why our project that Shereen already mentioned comes in. It's called Caring Community Living Labs, and you'll see the little logo on the right. It's the people holding hands. And the project investigates whether caring communities would actually improve long-term home care, specifically for people with chronic disease. And it is founded by the National Science Foundation, Switzerland, and is part of a broader research program on smarter healthcare. And we'll move on to the next slide, please. So what are caring communities and what do they want to achieve? On a conceptual level, caring communities put care at the very center of society. And that means that everybody is to be involved in caring and the process of caring and relationships of caring. That also somewhat disturbs this dyad of receiving care and giving care. Caring communities, as indicated by its name, focus on communities and make communities the very social fabric of caring relationships. On a practical level, that means, evidently, that care is to be brought back to the local level. And caring communities often have a sense of autonomy about them. And they seek to organize care across the different providers. So state providers, private providers, volunteering, civil society, family care, neighborhood care processes, etc. So there's really this intersection of different services. as a broad goal. They want to offer sustainable solutions for all settings, so rural settings, peripheral settings, and urban settings, which are evidently quite different. Quite a utopian goal. That is also one of the big criticisms about caring communities. Other than that, there is increasing concern that caring communities might lead to a sort of neoliberal shift of responsibilities away from state provision, for example, down to the community, and in particular, its members. So civil society, families, neighbors, and volunteers. We can move on to the next slide now, please. There is abounding feminist scholarship about care, and the literature is very comprehensive with a number of different strands. But for the purpose of today's presentation, I'll venture to compress the various debates within feminist scholarship about care to a central question of how can we make care more gender equitable. And so while caring communities do mark a very contemporary and also very visible application of the concept of care, there is indeed very little reference to those feminist debates, let alone gender. So what I would like to think about today in this talk is what are the two debates' central aims and claims, and how, if so, can they be combined? So now we can move on to the next slide. So I brought with me today 6 pairs of colorful circles. And in moss green, you'll see the feminist pillars of care debate. And in the berry color, you have the caring community aspects. If we start on the top left, we have a pair that says defeminize care and everybody cares. So the first one is that given that women still care both formally and informally, predominantly, some feminists have asked for care to be defeminized. Parallel to that, caring communities want everybody to care, for care to be at the center of society. So that brings us to the next pair, and that would be on the top right. Caring communities, feminist scholarship has this notion of ethics of care, which is a bit of a similar vein of everybody cares. However, caring communities, they propagate solidarity and sustainability. What does that mean? So they argue that in order to have a well-working care provision in the long run, we need to build on an ethics of sustainability, which works along the lines of, if I help you today, you'll help me tomorrow, and we'll be even, or it will be even. Okay, let's move on to the level of care provision. That would be a third pair, and the middle on the left. Some feminists have called for adequate and affordable public care services. Caring communities' answer to that demand is that the community itself provides care for itself. And we'll move on to the next pair to continue. And some feminist scholarship on care that demand that first and foremost, we need to address the underlying gendered social norms before we can even talk about community providing care for itself together. They argue that we need to radically rethink those gendered norms in order for care to become equitable and defeminized. Albeit the ostensibly somewhat utopian conceptual goal of caring communities, that care is to be placed at the center of society. In practice, actually, caring communities often start by working with the existing services. That means by coordinating and improving services that are already in place. Okay, we'll move on to the fifth pair. Much feminist scholarship claims that both formal and informal carers receive adequate pay and recognition for their effective labor and their care work. This is a central pillar in feminist scholarship, and while the notion of caring communities would not necessarily or explicitly disagree with that claim, caring communities still heavily rely upon unpaid labor, in particular from families, neighbors, and volunteers. So here there's a clear friction between two demands. And so to the last, the sixth pair on the bottom right. So for decades, feminist scholars have investigated the often invisibilized and increasingly globalized and global care chains, by which they mean the ways in which caring relationships are increasingly structured across countries and also generations. At the same time, caring communities have a clear focus on social quality on the local level. So they don't particularly look at the ways in which their local caring community might be contextualized or connected to the rest of the world. Okay, so let's move on to the next slide, please. So what can we learn from those six colorful pairs of circles? Can we, as postulated earlier, combine feminist care debates and caring communities? I would argue that in order to achieve this so-called utopia of caring communities, it is imperative to not only make care the center of social life conceptually, but also to really work towards adequate recognition and better pay, for the highly feminist domain of care work. Moreover, in order to engender those local sustainable cultures of interdependent care, we must not forget to address the structural inequalities and the contexts of local structures that are to be found on a global level. Moving on to the next slide, please. So, to conclude, caring communities and feminist scholarship on care have many similar goals. However, they often have a different focus and a different emphasis. So, for example, caring communities is a somewhat depoliticized notion because its highly local focus does not really radically question the underlying assumptions and the current structures and discourses around care. And we have seen that many feminist claims have been implicitly taken up or at least mirrored in some of caring communities' central pillars, and thus they've allowed feminist claims to have a larger audience, even if that audience might not be aware of their feminist heritage. So while there are similar goals, there are also similar hurdles and maybe also shortcomings. In particular, with caring communities, there is a continued middle-class white bias and certainly a very global north-inspired perspective. And in both cases, with pay and with answers, with questions regarding how to reach the populations that might actually benefit the most from both caring communities and feminist claims, we have not been able to find answers about how to reach those populations. And with that note, that we're still looking for answers regarding pressing questions of funding and how to reach the people that need to be addressed the most, I would like to end my presentation for today. And I thank you all very much for listening virtually at home around the world. And if you have any questions, don't hesitate to get in touch. My email address is here on the last slide.
Thanks, Katharina, very much for your very interesting presentation and investigating perhaps a well-rooted but maybe reimagined, reinforced concept of caring communities, and having this feminist perspective was really interesting. I would like now to welcome our third and final speaker, Alejandra Marroig, who will present a paper titled "Transitions into Dependency with Aging in Europe." Alejandra is a PhD candidate and a researcher at the Institute of Statistics, University of República of Uruguay. Her research focuses on the study of dependency, care needs, health, and well-being with a life course perspective, using longitudinal statistical methodologies. So without any further ado, the floor is yours, Alejandra, and we look forward to listening to your presentation.
Thank you very much, Shereen. And in this talk, I am going to present analysis of transitions into dependency with aging in Europe. That is a part of my PhD thesis. And I'm conducting with Graciela Muniz-Terrera from the University of Edinburgh. So the next slide, please. And this is an overview of the talk, so you can pass it, please, the next slide. So here I want to contextualize the analysis that we are going to conduct. And here I present what we mean by dependency, that is a multidimensional concept related to long-term care, but it's not exactly the same. So dependency is multidimensional, and it could involve functional, psychosocial, and support dimensions. And in our work, we refer to it as the need for support to perform activities for daily living due to lack or loss of physical or mental health. So meanwhile, the long-term care refers to the services that dependent people need, and we have informal care that is provided by an informal caregiver, and formal care that is provided on a contractual basis, and you have to pay for it. So the next slide, please. And so far, we know that with increasing age, care needs increases. And in general, the people need are for help in instrumental activities of daily living. And then with aging, there is an overlapping of need for help in both instrumental and basic activities of daily living. So among others, sex is an associated factor with dependency and functional abilities. We know that there is a male-female paradox survival, that male lives longer, the female lives longer with poorer health conditions, and also may need more support for daily activities. So also the type of care that these dependent people needs in the mix of formal and informal could be important to understand the quality of life of these people, how they met or don't met needs of care. And also we need to understand this care mix for the sustainability of the long-term care policies. So in this context, next slide, please. In this context, our objectives are to identify the profiles of dependent older people in relation to age and sex in 10 European countries. To address, also, we want to address the heterogeneity between countries that may highlight institutional or cultural difference, and also we want to address the heterogeneity between different measures or operationalizations of dependency construct. Finally, we aim to discuss these results in the context of the type of care that older people receive at home. So, next slide, please. To achieve these objectives, we estimate multi-state models that allow us to assess the effect of covariates of different variables on transitions between states, like the figure represents here. And we can compute the probability of transition to different states of dependency over time, and considering also death. So, next slide, please. For the estimation, we use the Survey of Health, Aging and Retirement in Europe, the SHARE, that is a multidisciplinary database that have 7 waves. But for our analysis, we use only the first 4 regular waves and the 10 countries that participated in all of them. And the population analyzed are people aged 65 years and older. So the next slide, please. With this data, we are able to operationalize dependency in at least two waves. And we first define or measure dependency by stating that a person is dependent if she has difficulty in at least one activity of daily living of those asked in SHARE, that are in total 13 activities. And then we operationalize, and these 13 includes all basic and instrumental activities of daily living. And in the second operationalization, we used the only consider the basic activities that are 6 asked in SHARE: dressing, walking across a room, bathing or showering, eating, getting in or out of bed, and going to the toilet. And this other operationalization is also with at least one activity of this out of these 6 basic activities. If they have difficulty, we consider them as dependent. So the next slide, please. Here I present some descriptives of the shared data that we use in the 4 waves from 2004 to 2013 in different colors represented in the left panel. We use the operationalization based in basic and instrumental activities, and in the right panel we use the operationalization based only in basic activities. And also we split the sample into 2 age groups, and we saw that the percentage of people with difficulties in these activities is very related with age. And also, if we consider the more comprehensive operationalization, dependency is higher than when we consider the operationalization based only in basic activities. So this is like, we are going to analyze what is going on, including also sex. So please go to the next slide, please. And the multi-states model allows to assess the effect of age on transitions to dependency. And here I present the hazard ratios that represent the risk of transition with an increasing age. So in the first column, there is the transition to dependency, and we estimate this for each 10 separately, the 10 European countries. And we can see that consistently for all countries, the increasing age is increasing the risk to transition to dependency. And this is also consistent between the both measures of dependency. In the top panel is the comprehensive assessment, and in the bottom panel is the basic assessment with basic activities. So the next slide, please. When we assess the effect of sex, here we are going to present the hazard ratios of being of females in respect to men. And now we can see that in the first column, the risk of transition to dependency is heterogeneity, is diverse between countries and also between the both operationalizations. In the bottom panel, the first column, we can see that being a woman only increases the risk of transition to dependency in Spain, Italy, and Belgium, but not in the other countries. But when we assess the dependency with a more comprehensive, then almost all countries have differences in the risk of transition to dependency for women that are more at risk of dependency than men. Only in Sweden, Switzerland, and Denmark, these differences are not statistically significant. So then we analyze the probability of transition to dependency in each country. So next slide, please. And here we plot the probability of transition over time for each country for men, that is plotted in the light blue color, and for women in the pink color. And we can see that for every country, this probability increases for everybody until 70 years old, but for women is all along higher than for men. In some countries, these differences are more important, like in Spain or in Belgium, for instance, or Italy. Thank you. So next slide, please. When we assess the dependency with only basic activities, these differences between men and women are not so pronounced as in the more comprehensive operationalization. So finally, we want to analyze with which type of care these older people receive in each country, and this difference between sex. So next slide, please. Here we can separate in groups of type of received care at home for each country, and we separate in three groups: the people that do not receive care at home, the people that receive a combined mix of paid or unpaid care at home, and the people that receive only unpaid or not professional care at home. And this figure shows that there is heterogeneity between countries and also between sex within these countries. So, for instance, we have that for all countries, the men has always a higher percentage of people that don't receive care at home, and this is consistently across all countries. And in the other hand, women receive more unpaid or not professional home care than men. So we can see that this is differences between sex. Also, we can see differences between countries. For instance, in Netherlands or in Switzerland, the percentage of people that receive unpaid care at home, they are very lower than in other countries like Spain or Italy. So next slide, please. To conclude and finally this session, we can see that this work found that transitions varied with age, and there are consistently differences. There are consistently increases in transitions to dependency across countries until 70 years old. And for women, these are higher in some countries. But when we use the comprehensive assessment of dependency, these differences are more pronounced. And also to refer to the type of care, next slide, please, and the last one, the type of care received for people with 65 years old and older is different between countries and also within countries, between sex. So maybe it's interesting to deepen the knowledge about which difficulties in which type of activities and then which type of care they receive, and relate these to the met or unmet needs that dependent people have, and how these could affect the quality of life in these European countries. So thank you very much for this presentation.
Thank you so much, Alejandra, for the in-depth comparative analysis of the multidimensional concept of dependency and its relationship with the types of care. I really like the comparative manner and the use of statistics. And also it's very interesting to see the kind of gender differences, both in the dependency transition probabilities, but also in relation to the type of care received in different countries. So I would like now to introduce our discussant for this session, Professor Jill Manthorpe. Jill is a professor of social work at King's College London and the director of the NIHR Health and Social Care Workforce Research Unit based in the Policy Institute at King's. Very warm welcome, Jill, and I'm looking forward to a very lively discussion.
Great. Thank you, everybody, and particularly thanks to our presenters who've made for a really stimulating and thought-provoking contribution to this conference. I know that we've had many presentations from around the globe, and how fantastic it is to have people from so many different backgrounds all thinking and encouraging us to think about this issue of care mix and, of course, ageing in place. I've got 4 points which I thought we might find useful to think about in relation to the very wide range of studies that have been reported here. The first is how good it was to hear some ideas about the why questions. Why is this happening? What is it? And what are the explanations for the changes that people are talking about, but also the continuities of care? So when I'm thinking about the presentation by Katharina from Switzerland, why are people talking about communities of care? What is so magic about this word community, which is often seen as perhaps rather soft and emotionally value-laden? Why is that happening? And what are the consequences for equalities as well as inequalities between different genders? Similarly, with Miko, the why people care within families is so important and so little understood. And he pointed out that for people working in practice, but also people in policy, that understanding the why is a really important question, because you can make laws and policies and procedures, but unless you begin to understand why, you will not go with the grain of people's wishes and experiences. And similarly with Alexandra from Uruguay, how important to understand why it is these trends are happening, not only in respect of gender, which is what she was examining in particular, and of course in relation to different countries or states, but why this disability, this growing disability among a population which is probably the healthiest we've ever seen on this planet. Why certain things are so problematic, what is it about age physiologically, but also culturally and environmentally that increases people's disability and therefore perhaps their dependency. Focusing on that, there is of course the question of why not. And I think that all of the contributions made today illustrate some of those ideas about why not. Why is it? Why is it that some people do care, but of course others do not? And in the presentation by Miko, clearly the focus was on people who are providing a tremendous amount of care at great personal cost sometimes, and of course to other parts of their lives. So why is it that some people do and why not in relation to other people? Because we know that there are carers, but there are also people who take a decision not to care, and indeed people who take a decision not to be cared for by their relatives or friends. The other why not questions could be why people don't get care, as Alexandra was talking about, from services. Is it that the care is not available, or perhaps it is not acceptable for them to have care coming into their homes? And Katharina also raised some why not questions. What is it that in terms of the huge female voting power within all the democracies talked about today, why is it that care does not have a higher public profile? So that was one point that I thought arose from all three of those publications. The second point is the value of social science methodologies, and I'm including mathematics and statistics in this because, okay, I do think it's as much an art as well as a science. But how super it is to see new attempts to take forward methodology, both in relation to statistical methodology, but also in the use of things like photo voice and other debates which are really important. And then the methodologies around policy analysis and documentary analysis and spotting trends that emerge through political science, as reflected in our contribution from Switzerland. So great to see methodological and thereby theoretical developments emerging from these all three perspectives presented here today. My third point is I've sat for an hour and nobody has mentioned the word COVID or coronavirus. That's pretty unusual, isn't it? And I wondered if we might ask our contributors to think and to discuss with us what the impact of a global pandemic will be upon the issues that they're thinking about on probably a day-to-day basis. It may be that aging in place takes on a different dimension in developed countries where there have been many choices open to people about where they wish to age in terms of physical location. It may be that coronavirus has had some really fundamental changes to our thinking about family obligations and the choices we make and the options that are available to us, and in some cases are not available to us throughout the last year. And of course, COVID will not be over, will it? It will continue, and so too will other infections to force us to adapt how we're thinking about care in a world that is aging, and the different pressures from infections, from pandemic, and from the economic upheaval and disruption that is caused. And then lastly, in my fourth point, I wanted to talk about the involvement of people using care services and also of family and friend carers themselves in research. I think we're beginning to see how valuable it is not to all the time co-produce, which involves people working on a subject, thinking through the question from early stages, which may be possible and sometimes is, sometimes isn't, but really to build in more of the viewpoints from people we're talking with to help them tease out the answers to our questions, which are around why and why not. I think that perhaps is the stage that we're going to work with in our new studies and also reflect upon in our older studies about how carers and care recipients can be involved, taking through this understanding. And of course, for some people, statistics and maths are not easy to understand, but in many ways we've got to explain to lay public because that's who politicians are. Likewise, not every carer or care recipient is going to be deep in the heart of methodologies such as IPA, But they often get it. And of course, thinking about photos is immediately accessible to many people, and carers perhaps have their own stories to tell about what images and cultural associations matter to them. And of course, carers have a political voice, and so do care recipients. And their views will be very important, I think, in determining whether or not caring communities has any future traction. And I know we will all be very interested to see what's happening in Switzerland from this new development. So that's my initial thoughts on the presentations. I would like again to thank the contributors and Shereen for this excellent session, which has made me think and shown the value of listening internationally to what's happening in caring debates, and to draw on new ideas of methods and of understanding and concepts that are around globally. Because clearly when we're talking about care challenges, this is not a simple one nation issue or a one town issue. It's affecting us all very much globally. So thank you to everybody. It's been an absolute pleasure listening to all the presentations and how clear and concise they all were, and what great food for thought they've provided us with. Thank you.
Thank you so much, Jill, for a great discussion and further point to catch on. And I would like now to invite our speakers, Miko, Katharina, Alejandra, to join in the discussion and maybe to respond to some of the points that Jill has made. And really, Jill made these 4 overarching points, which, cuts across all the presentations about the why and why not, about the methodologies that has been adapted and their varieties, and about the role of service users and carers, and lastly but not least, of course, the implications of the pandemic and COVID, which is changing not only the way we're doing research but also how we're looking at research and the findings and how can we learn from them. So if I can invite Miko first and perhaps focus on this point of why not. So I was really interested when you were talking about the motivations of people to provide care, and straight away I was thinking, what about not to provide care? And it was really interesting that Jill also highlighted this point, and what would compromise this. So we know that there is a huge interest in informal care, and this is, as you said, it's something embedded within the family, and that links really also well with Katharina's point about communities and from a gender perspective, the assumption that we work on. So if you start with Miko and then maybe take the thread to Katharina and then to Alejandra.
Yes, thank you both, Jill and Shereen. It was great to hear all your comments. And it's great to hear that there's so much food for thinking, and also your discussion, Jill, had made me thinking about it more as well. And related to these questions, really, so that's one of the drawbacks, really, of informal caregiving research, also in qualitative, bit. So when we did this big meta synthesis, and we had there 105 qualitative studies included, they all referred to people who choose to care, not those who relinquish the caring responsibility. And we don't actually, know why these people chose not to do that. And that's a very important question that needs to be addressed, to be honest, to fully understand how the motivations work, for informal caregivers. So I fully agree. I think it's a crucial question. And also in relation to Katharina's, discourse on the community, from my study, which of course consisted of a very small sample of people who chose to care and who were devoted, actually, most of them were really devoted to what they did. But they also had, some contextual, situational circumstances that allowed them to do that. Of course, in other circumstances, this might not have been so clear. So they could clearly say that family is very important, that it is a high value, that they feel obliged to do that, and that they wanted to do that. But at the same time, there were a lot of contextual factors that contributed to this, why they chose to do that. and that shouldn't be an indicator for community-based care, basically, because there are, as Katharina has shown, there are many other factors that needs to be acknowledged. And even, even these caregivers, I haven't had time to show that, but they have also expressed sometimes contradictory motivations. And that's why this should be also put forward. I said about, going beyond the basic dichotomy of intrinsic and extrinsic motivations, but I could go even further. Sometimes caregivers might express like different levels of motivations, and some of them might be contradictory. So, they might at the same time wanting to care, and they might not want to care for different reasons. So I think that first, it's a very complex issue, and the second, that there are these factors that needs to be addressed when answering this big question that Jill posed: why not, and why?
Thanks, Miko. You actually point out to something really important, which is the publication bias that we all live in. So you tend to have lots of studies on what's happening, but not what's not happening, which in many policy, it's really important to know why things are not happening. So thus the focus of the research has to be we need to know why we're not seeing this. What about the people who choose no? And I think that links also very well to Katharina's discussion around communities. And I was really, listening to you, wondering about all these shifts of responsibilities and this reimagining the concept that we are a community, but we all know that actually these communities have been mobilized. You don't have a stable neighborhood in many places. You have a very mobile population. You have the families moving away. You actually have a lot of older people do not have families. Maybe they decided not to have children. And I think it's from your kind of feminist perspective, because that was really interesting, that we still going back to assumed responsibilities. So we're falling back on women. So even if we talk about a gender neutral community, it's never gender neutral. So maybe take this line of discussion, and that would link again to the gender differences that Alejandra was talking about in her study. So if you just reflect on the why not, but also what's the, where are we going with these notions of communities of care, as if we are, where is the imagination and where is the reality when we talk about communities of care?
Thank you very much, Shereen, for this wonderful question, and thank you, Jill, for your amazing summary. I would like to start with the first question that you raised, Shereen, regarding the why not, and really links to the co-production that you mentioned, Jill. And it really is it's a big issue, actually, because we realize, conducting a participatory project, that we don't actually manage to really address the people who we want to address. And that's not only the so-called hard-to-reach populations that I mentioned, but just, the community. And that leads to that second question you posed, Shereen: who is the community? And that is a fundamental question, because, it is really something kind of top-down to be defined, and I think there is a lot of resistance, particularly in today's world. And one of the so-called living labs that I do here in Zurich, it is a very, for Zurich standards, okay, for Swiss standards, it's a very mixed community, which, might not be able to compare to other places. But it's really difficult to then say who is this community, and how can we actually even think about a caring community if that notion is more, as you said, an imaginary community than an actual community. And I think that's the normative aspect in this concept. And to return to your question regarding the shifts of responsibility, in Germany that was a huge issue, because due to funding cuts, austerity measures, etc., caring communities have been sort of used as a tool to actually shift responsibility away from state provision or general provision down to the lowest level, which often is, in political terms, the community, and in social terms, the family or the individual. And that is something I think that is a huge danger there, and it's really hard to, because if you want to actually engender a caring community you don't know, you can't control it. So it's a danger.
Or you can't mobilize it. Yeah. Absolutely. So, Alejandra, it was wonderful actually to see you utilizing such large data sets in a very kind of a brilliant way, using a multi-state kind of analysis model, which is not often used, but it's really powerful because it gives you all these detailed information about the hazard rate and transition probabilities. And I was really interested to see the heterogeneity across countries, particularly when we were talking about gender. So obviously you mentioned Spain and Belgium and Italy particularly having huge kind of heterogeneity in terms of the transition of dependency. And I was wondering whether this is something linked to the welfare model within these countries, because that links back to the informal care model, because in these countries in Southern Europe, the reliance very much is in informal care, on the community, again, on these kind of the invisible people, and a lot of them end up with having a migrant live-in carer in the family rather than really a community. So if you can talk a little bit more about these differences, linking back to Jill's question that, we're talking about Europe, the most healthiest in the world, perhaps, and why we're still seeing these differentials in dependency ratios. We will have to see a dependency moving to different states because this is how the aging process happen. But maybe elaborate more about these heterogeneities, particularly around the 6 differences.
Okay, thank you very much, Shereen and Jill. Yes, it's what we want to do with this is to highlight that in the macro level, when you see the countries in Europe, the healthiest population now, we can see that welfare models can be behind this type of care received. And this is not bad because if you paid for care, it's better than if you don't pay, but you have to know that culture and the institutions in each country and the people's what they need and what they want are going to be different if you live in Italy or if you live in Denmark, and the policies of long-term care may need to make the policies. Also, what we want to highlight here is that within countries, this type of care received is also different between men and women. So maybe it's not only in the macro level, the differences, it's also interacted with the sex difference within the country. So maybe these policies in each country needs to take into account not only the cultures of the general, but also the sex differences, because women and men may need different type of care, or may be happy, or maybe met or unmet needs with different with diverse type. So I think this our work is going to, or wants to put this into the discussion of the research of when you design a policy that goes to home care in Italy, you may take into account that men and women are different and they may need different type of care at home than in other countries, or in that way. So that is what we want to highlight.
Thanks, Alejandra. I think I would like in the last minute to go back to one of Jill's questions, one of the last questions around COVID, because we, obviously a lot of your research has been conducted prior to COVID, but we are living in the reality of COVID. And unfortunately, and as Jill said, we're not going to get rid of COVID. And even if we got rid of COVID, we will be living with a lot of consequences. So maybe if you can reflect on your studies, and maybe with the pandemic in mind. And think perhaps we start with Miko, thinking about the motivations of informal carers, and then Katharina reflecting on these communities. So we are now actually, perhaps we've seen with COVID that the physical communities become more important. So neighbors and shopping for older neighbors and kind of checking out and phone calls became more important. And maybe again, if Alejandra can think about, from a macro level and from a statistical point of view, maybe how we can capture that later on, that would be really great. So we've got maybe 8 minutes to discuss this. So if we start with Miko.
Yes, so of course the study was conducted prior to COVID. So, it was in the situation where the caregivers and the recipients were able to reflect upon this. But just discussing and considering this in relation to COVID, I think it has obvious implications for this contextual factors. If some caregiver was providing care and had to commute, for example, to the care recipient, there were problems. The study was conducted in North Wales, and usually people have to move around with problems, with flooding, which also made caregiving sometimes difficult, and was also expressed by caregivers. And with COVID, of course, the worries about contracting COVID were obvious, I think, for people, and I think they put a lot of pressure on them. So I think they had to change the pattern, how many of them provided care. Of course, some caregivers resided with their care recipient, but it was not the case for all. So this had to be, and I guess the access to the formal support, I guess it might have been reduced. The caregivers, not all of them, but some of them have expressed the views of difficulties accessing formal support provision. But sometimes even if they have this access, the perceptions were quite negative and apprehensive. And this, relates to different issues. For example, the two caregivers who provided care to their siblings, they had a perception that they are treated as a kind of an enemy for the state, because they had to manage, for example, their sibling finances, and this raised another issue, because their siblings couldn't do that themselves. Basically, that they had no ability after the brain injury. So they were apprehensive about it because they wanted to care, but they didn't know how to approach that formally, and they felt that formal services were not helpful, but sometimes they were even hindering this. They had no formal training for this. So with COVID situation, I presume it might have put more pressure on them, doing all this.
Yeah. Thank you. And maybe Katharina, the kind of, the ideas that actually the community is there, and with COVID, we are physically not able to visit our families who live far away. And kind of this, in some places in Europe, communities became quite important during COVID. And whether you think that would be temporary, how that would interact with these notions of communities of care.
Yeah, I think for our study, it worked a bit like a magnifying glass. So we were 1 year in when the pandemic started last year, and for me, it really showed how certain structures just continued and were more visible. So what do I mean by that is that I think there was a temporary surge, particularly for things that you mentioned, the shopping and that sort of civil solidarity movement, but that was only temporary. Many people were very sort of reclusive, and they wanted to continue doing their own thing. I think something like you mentioned now, Miko, and I'm not really sure if the fundamental values have been really shaken as of yet. So in the study, we really saw a lot of older people who were just they didn't meet anybody. They didn't have their family come visit, and if the family members or neighbors did anything, they left the shopping outside of the door. And you really had some very touching moments in interviews over the phone, obviously, where people have just told me that they haven't been touched in a year. Then the only thing they want is for their family member to come visit them and hug them. So that's really what I mean. I think with aging trends and individualization, it's a bit like a magnifying glass, I think.
Yeah, absolutely. Absolutely. And deconditioning as well, which is another element maybe leading to the transition to dependency. So with the pandemic, Alejandra, would you think that people were forced to stay at home, that this will accelerate the transition to dependency because they are not going out, they are not using their muscles, they are not living,
Yes.
even the cognitive stimulating life they used to do before COVID?
Yes, I totally agree with that, Shereen, because I think older people in this pandemic are suffering a lot of, isolation, and this could be also not only in functional disability, but also mental health that could lead to dependency and could accelerate this process of, aging and being more with more disabilities in different activities. And also maybe they could not have the care that they need at home, because the carer now is not be able to go to their homes to care. And I think this COVID pandemic will be negative, very negative for all countries. I think it's going to be across all countries in Europe and in the globe, everything.
It will be definitely interesting to look at similar analysis of what you presented here using recent data, because the impact on kind of lockdown and isolation will be significant on many, on most of older people. So it would be really interesting to do a repeat of your, kind of trend analysis with new data point. I really enjoyed this session. It has been very thought-provoking. We had wonderful speakers. We didn't have time to speak about methodologies, but this is for another discussion. It was really good to see the variety of methodologies applied, which mean that care, as we know, is something that is multidisciplinary, complex, and we can look at it from a different perspective every time, and we can try to connect these methodologies and ideas in a more coherent way, as we're doing within this conference. So I would like to thank everybody. I would like to thank our speakers, Miko, Katharina, Alejandra, and our discussion, Jill. And thank you for everyone who's watching us. And I really look forward to meet you, many people in other sessions of the conference and in our kind of research and academic life. Thanks, everybody. Have a wonderful day, evening, morning, wherever you are. Thanks.
Thank you.
Bye. Thank you.
Thank you.